Hello, everyone. Thank you for joining us today for our annual Survivorship Conference. Once again, this year we are virtual. I'd like to thank you all for joining us. I'm going to introduce Dr. Jeffery Peppercorn, who will then introduce our speakers, Dr. Ryan Sullivan, Dr. Giselle Perez, excuse me. But before we do that, I'm just going to go over a couple of housekeeping items. Today, as part of this webinar, you are in listen-only mode. That's to minimize any audio distractions, but we do welcome your questions and we'll have time at the end for Q&A. So if there's something you'd like to ask, you can type it into the chat box. This session is being recorded and it will be posted to our website for anyone who may miss it or if you'd like to watch it again. And lastly, we ask that you don't share any personal medical information or questions in the chat box. If you have a medical question, please ask your doctor. And now I'd like to turn it over to Dr. Jeffery Peppercorn. He is a breast oncologist and the director of supportive care and survivorship at Mass General Cancer Center. Jeff, I turn it over to you.
Thanks, Devin. Well, thanks for everybody who's joining us. We wish we could all be together and hopefully we will be again someday, but we're very glad we have the technology to do this virtually, which is also somewhat good because people can do it from the comfort of their homes or offices. So we have two fantastic talks today from Dr. Ryan Sullivan and Dr. Giselle Perez. I'll introduce both speakers right before they speak. We'll have questions at the end. They are both linked to the theme of cancer survivorship, but from really different angles. So hopefully you'll all be able to take something away from this today. And as we said, we welcome any questions or comments in the chat. So the first talk is going to be from Dr. Ryan Sullivan, who is a medical oncologist, an attending physician in the Division of Hematology Oncology at Mass General Hospital, and associate professor of medicine at Harvard Medical School. At the MGH, he's the associate director of the Melanoma program at our cancer center and a member of the Termeer Center for Targeted Therapy. He's an active clinician and translational investigator whose main areas of interest are development of novel molecular targeted and immunotherapy combinations for malignant melanoma, as well as other solid tumors. And he's been interested in describing, predicting, and of course, optimally treating immune-related adverse events from immune checkpoint inhibition, one of the therapies you'll be hearing more about today. And he is a member and a leader in multiple national oncology organizations. We're very lucky to have him at our cancer center and speaking to us today. So thank you, Dr. Sullivan. Take it away.
Thank you so much, Dr. Peppercorn. A kind of introduction. I apologize for any background noise. I'm actually hanging out with my son today at a football camp and it's noisy. So hopefully it won't be too distracting. So my task today is to talk about melanoma survivorship, and I've sort of subtitled this Considerations for a New Era. Of course, if we're in a new era, we have to talk about sort of the era we have been in. Briefly, I'll just list my disclosures that are here. So the treatment of melanoma actually involves a number of different potential treatments. There's a diagnosis, of course, that has to be made. Most patients who are diagnosed will have a thin melanoma that will be removed either by a dermatologist or a surgeon, and that'll be the end of their surgery and the end of their treatment. And they'll be cured with therapy, and 97% of patients with a thin melanoma are cured with a limited surgical procedure. However, in bulkier tumors or tumors that have already spread to lymph nodes, we have a number of different types of therapy, including neoadjuvant therapy. Neoadjuvant therapy is therapy given before curative intent surgery. We, of course, have curative intent surgery, which can include an excision of the tumor, but also can involve a sentinel lymph node procedure where we harvest lymph nodes and analyze them. And then we have adjuvant therapy, which is given to patients who are at high risk of recurrence to help reduce that risk, essentially to improve the cure rate of the curative intent surgery. And then we have therapy for patients who develop metastatic disease outside the regional area. And we'll talk a bit about all of those things and then some of the survivorship issues that we have regarding all of those. We'll start with surgery. So the standard surgical management for melanoma, I alluded to earlier, is a wide excision and sentinel lymph node biopsy. The majority of patients who have these procedures are cured. prior to 2017, very specifically June 2017, when a publication of a really important paper came out, what we would do is the wide excision was performed at the same time as the sentinel lymph node. If the sentinel lymph node was positive, meaning if there was cancer cells identified in those lymph nodes, then the surgeon would take the patient back for a second surgery to remove all of the lymph nodes in that area. For example, if the melanoma was on the leg and the lymph node, a positive sentinel lymph node was in the groin, we would remove all of the lymph nodes in that groin. And that had very significant implications for patients, because when you remove all the lymph nodes in a lymph node basin, whether it's in the groin or in the arm or even in the neck, there can be swelling and long-term consequences of that that have to be managed and are certainly have an important impact on quality of life. Interestingly, after June 2017, there was this paper that came out that really showed that doing that second surgery didn't improve whether patients were alive or not 5 and 10 years later, nor did it really impact the chance of there being distant metastases. And so literally overnight, that paper came out and we changed the way we did surgery, and importantly, impacted the long-term effects of surgery, and essentially eliminated or lessened the chances of those long-term effects of surgery. And so anytime now a patient is diagnosed and they have a positive sentinel node, we do not do the completion node dissection, but instead we'll end up doing monitoring of that lymph node basin with ultrasound, but not with surgery. Standard radiation therapy was also a common practice for patients who had high-risk melanoma, particularly who presented with their diagnosis, had big lymph nodes in the lymph node basin. So a lymph node is essentially drained from an area of skin, and so the lymph node basin is that area where the lymph nodes sit. And if there were lots of lymph nodes or bulky lymph nodes, we commonly would recommend radiation after the completion of surgery. And very similarly, radiation would have impacts on quality of life, where they would impact swelling. So lymphedema was very common after surgery. And additionally, we would commonly see skin changes. And anytime radiation is done, there's also the possibility of there being a secondary malignancy in the area of radiation. So the fact that we were able to change the way these were done, again, the reason we don't, I should say, there was another randomized trial in radiation therapy that showed, again, randomizing patients to radiation or observation, a trial that honestly, it was hard to accrue to, because we never thought that it was right to not do radiation, but this is a sort of importance to clinical trials. And this showed that there was no improvement of survival, and again, reduced the chances. It reduced the chances of radiation or of metastasis recurring in the radiation field, but not anywhere else. And so this practice was stopped. So that's sort of a very brief history of what's changed in the last 10 years with regards to surgery and radiation. What else has changed is the therapies we use to help prevent recurrence of melanoma. So traditionally, there are very few therapies. This is true for patients who had high-risk melanoma removed, but also true for patients who had tumors that recurred and they had advanced metastatic disease. We had a chemotherapy that was approved basically by default in the 70s called dacarbazine or DTIC, and there were 2 immune therapies approved in the 90s, which showed some benefit in some patients. But these were not widely used in all centers across the country or the world. And I like to consider this era the era of futility, not because our patients were futile, not because the people who were trying to develop therapies were futile, but because the drugs we had to offer patients didn't work very well. And this is the only Kaplan-Meier curve I'm going to show, the only survival curve I'll show. But before 2000, this is between 1975 and 2005, but over 2,000 patients who were enrolled onto clinical trials who had advanced melanoma. And it shows that at 24 months, over 85% of patients were deceased. At 36 months, less than 10% of patients were still alive. And that was where we were. Amazing things happened during those 30 years where we kept doing clinical. The first thing that happened is we really learned how the immune system interacts with cancer. On the left is a completely crazy graph about how the immune cells interact with other immune cells, interact with tumor. The thing that I think is important to highlight is, one, there are factors that activate and factors that prevent activation of the immune system. And two, we actually know how to target these now. So CTLA-4 is a target. It's a protein that's on immune cells, and we actually have a drug called ipilimumab that targets that. PD-1, PD-L1 are targets on the immune cells as well as cancer. We have drugs that target PD-1. We have drugs that target PD-L1 that are approved for melanoma. And importantly, another protein called LAG-3 is a recently identified target, and we have a drug that works to help improve outcomes in patients with metastatic cancer. So that's one thing that happened during these 30 years of futility. The other thing that happened is we really learned how that melanoma is a cancer of genes, and that genetic alterations lead to changes in the way that the cancer cells work. And so we learned that half of patients have a mutation in something called BRAF, another quarter of patients have a mutation in something called NRAS. And importantly, we learned a little bit about how these mutations signal, and we identified targets by doing that, and drugs that block those targets. And so for adjuvant melanoma, these are drugs that are given after surgery. We had the immune therapies, interferon. Interferon could be given intravenously, high dose, or it could be given by a subcutaneous injection once a week. And since 2017, we now have data in stage 3 melanoma, which means melanoma that's spread to regional lymph nodes, that anti-PD-1 therapy, these are drugs called pembrolizumab or Keytruda or nivolumab or Opdivo, are approved in standard of care for patients to reduce the risk of recurrence in those patients. We also learned that there's possible benefit to combination immunotherapy in some patients who have resected stage 4 disease, but that combination wasn't particularly effective in stage 3 disease. And we also have combination therapy with drugs that target BRAF mutation signaling, so blocking BRAF and blocking a downstream protein called MEK, and that those combinations improve outcomes in patients with stage 3 melanoma whose tumors have a BRAF mutation. We also have data with stage 2 melanoma with one of the PD-1 blocking drugs called pembrolizumab or Keytruda, and that's become a standard of care option for patients who have resected high-risk stage 2 disease. So we now have basically 2 drugs and a 2-drug combination that are approved for stage 2, and a 1 drug that's approved, for stage 3, and 1 drug is approved for stage 2. And this is just highlighting some of those changes. Nivolumab is a PD-1 blocking drug, pembrolizumab is a PD-1 blocking drug, and dabrafenib, trametinib, or BRAF, and MEK inhibitor therapy. It's important to summarize a little bit the way that these drugs work from a side effect standpoint. So when we look at patients who are treated, and we compare side effect severity and frequency, interferon was actually pretty toxic. It didn't work that well, but it was toxic. Ipilimumab is really toxic and more toxic than placebo. It's actually more toxic than nivolumab. We anticipate it being more toxic than pembrolizumab, and in trials it looked that way in stage 4 disease. And dabrafenib, trametinib is more toxic than placebo. And these are just sort of summarizing some of the trials that have been done and comparing. But interestingly, the permanence of toxicity is very different when you think about the different drugs. Interferon has some permanent toxicity, but it's very uncommon. Less than 5% of patients would have some permanent toxicity. Ipilimumab, relatively common to have permanent toxicity. Nivolumab has similar permanent toxicity, and pembrolizumab has way more permanent toxicity than placebo, and dabrafenib, trametinib has about the same permanent toxicity as placebo. And the reason that is dabrafenib, trametinib is very much like any other drug that we've ever thought of or have taken in the past. If you have a side effect from the drug, it's because there's the level in your body of that drug, and when the drug clears your body, the side effect goes away. And that's how dabrafenib and trametinib works. Pembrolizumab, nivolumab, ipilimumab actually cause side effects by interacting with your body's immune system, are the way that our body interacts with itself. It fights off our infections, it fights off cancer, but if we overactivate it, the side effects can actually linger, and some can be permanent. This is a trial that we did. It's actually retrospective. So we looked back at almost 400 patients across 8 centers in the United States and Australia. And what we found was that of all the patients that we treated, about 20% of patients had acute, meaning happened quickly, grade 3 or 4 or 5 sides. So grade 3 side effects are severe, grade 4 life-threatening, grade 5 are fatal. So about 20% of patients have significant severe or life-threatening side effects when we use these drugs. But when we look across over time, the types of side effects that stick around are arthritis, a little bit of diarrhea, but less so. Skin side effects can stick around for a while, liver side effects can stick around for a while, and thyroid side effects stick around for a while. And if we looked at all these patients, over 40% had a chronic side effect. It was defined as lasting for more than 12 weeks after the last dose of therapy. And the most common were endocrinopathies, which were inflammation of the thyroid, inflammation of the pituitary, or arthritis, arthralgias, which are inflammation of joints. And so to summarize what we do for stage 2 and 3, we have changes in surgical management that reduce long-term complications. We've reduced the use of adjuvant radiation therapy, which has reduced long-term complications of radiation. We have BRAF targeted therapy and immune targeted therapies that are similarly effective in stage 3 melanoma in terms of reducing risk, but they have very different side effects. And I think it's important to note from a survivorship standpoint that way more patients are surviving now. So more people are cured at stage 2 and stage 3 melanoma. That's amazing. But long-term management is required, particularly for joint side effects, and particularly for these endocrine side effects, most commonly thyroid side effects. So let's briefly talk about stage 4 melanoma. I've introduced some of these drugs, but this is the change that's happened in a little over a decade. We had 2 drugs approved for advanced or stage 4 melanoma, and we now have 13 drugs, including 4 or 5 combinations of drugs. We have drugs in red, which block BRAF and or MEK. So these are, I term, BRAF targeted therapies. In the drugs in darker blue are the immune therapies that we use. And the way I'd summarize this is about 5% long-term survival for patients with advanced melanoma prior to 2011 when these drugs became widely available. Now, over half of patients diagnosed with advanced melanoma will be alive 5 years from now. And it'll likely be better than that because our therapies seem to be improving. And so again, not just more people are surviving high-risk melanoma, more people are surviving advanced melanoma. And the use of traditional chemotherapy and radiation therapy are less common, and these can have their own survivorship issues. But immunotherapy is the standard therapy for patients with advanced melanoma. We tend to treat for about a year of therapy, and in patients who have excellent responses, we then stop therapy. These therapies can have chronic side effects. I mentioned those earlier, and so long-term management and follow-up is required. And so about right just before the pandemic hit, one of our nurse practitioners named Riley Fadden met with me and met with Dr. Peppercorn and met with folks from our bone marrow transplant unit and really kind of dug in and said, you know what, we're not doing a good enough job of managing the survivorship of our patients who are on immunotherapy. There are key things that happen with immune therapy. Obviously we want to do a better job of managing the emotional and the social and physical issues from treatment. And we didn't feel like we were doing a good enough job. And so Riley began to design this clinic, and it went live in January of 2021. There was one half day of clinic per month, although it was on a Monday, so it could be third or fourth Monday, depending on holidays. A social worker, Leanne Miller, was part of it. She would meet with the patients, and then Riley would meet. 1 to 2 weeks, a care plan was generated for the patients, scanned into the chart. And then 2 weeks afterwards, one of our practice nurses would call the primary care doctor and the patient to review the care plan and answer any questions. And the goal was to meet patients about 6 months after completing the inclusion, exclusion. The inclusion exclusion for being part of this was that they had received immunotherapy, ideally for melanoma, because that's what we started, but then we began to extend it to patients who had cutaneous or skin squamous cell cancer and Merkel cancer. Had to be 6 to 12 months after the immunotherapy had completed and or completed any steroids or immune suppression for an active inflammatory condition. And we had 6 months of scan review and and medical appointment. Exclusion, so meaning they had to have sort of had their scans that showed that everything looked good and they had met with their oncologist. From an exclusion standpoint, we said anybody who had received immunotherapy, we were only looking for immunotherapy treated patients, not patients who had not been treated. And we also had any patient who was currently receiving other anti-cancer therapy, we didn't treat those people either. And then patients who are having active toxicities that required immune suppression. Riley would send out, she developed this and then sent this out to patients ahead of time. So this was a survivorship survey. And then this is just not an example, but just shows sort of a little bit about what a patient would receive and what would get into the chart, which was all of this information, the diagnosis, the treatment history, any side effects that patients had, any treatment for side effects that patients had, imaging, and then other issues that were ongoing were listed in here, and then the care plan about what we were going to do about it. And for many reasons, this got launched, and about 10 patients were kind of launched into it, and then we backed off a little bit just because our social worker was out for a few months and then the job, and so we're now kind of revamping this. Although we're beginning to reset this again, and we anticipate that we're going to start. I actually saw a patient yesterday, and I referred that patient to the survivorship clinic. So we're really trying to make this something that all of our patients who are treated with immune therapy can have, and again have a place for patients to talk about their experience, but then also for us to make a plan for the things that we anticipate could happen, and the management the problems that patients do have, and go from there. And again, this is a situation that we didn't unfortunately need much survivorship in melanoma for the many decades preceding this past decade. But it's becoming a real need now, and it's something that we're really passionate and excited to offer to our patients, and hopefully learn from our patients, have our patients learn from us, and then be able to tell other people about our experience. So in summary, we've entered an era in the treatment of patients with melanoma that many of our patients, probably most of our patients, will be long-term survivors. And the changes in standard of care to surgery and post-surgical management with lower risk of lingering issues such as chronic radiation changes and lymphedema, improvements in outcomes with post-surgical treatments like immunotherapy and BRAF-targeted therapy have improved the outcomes of some patients with stage 2 and stage 3 melanoma. BRAF-targeted therapies associated with toxicity that may impair quality of life, but rarely persist after holding or discontinuing therapy, whereas immunotherapy is associated with immune-related side effects that are inflammatory in nature and can be long-lasting or permanent. And so we've launched a survivorship clinic pilot for patients who have completed immunotherapy. This is led by Riley Fadden, and we hope to open this up further in the coming months as we have stabilization of our clinic personnel. I look forward to our discussion later, and I thank you for your kind attention.
Dr. Sullivan, thank you so much. That is a whirlwind tour of both the landscape and the changes in local and systemic therapy. I think everyone in the audience appreciated. I know you and I trained around the same time and really witnessed this over the course of our career. And as you highlighted, these new challenges, which are major challenges in the care of survivors, are a great problem to have, right? I mean, it's incredible going from a dismal 5-year survival rate to more than 50% of people having a good chance of doing well for 5 years or longer, even with the most advanced disease. So I'll have some more questions for you later. If people have questions specific for Dr. Sullivan, put them in the chat. We'll probably only be able to get to 1 or 2, but we'll comb through them, and sometimes I can answer them in real time, as I did. So with that, we will turn now to my colleague, Dr. Giselle Perez, who is a clinical health psychologist at Mass General Hospital and assistant professor of psychology at Harvard Medical School. She is the director of the Adolescent and Young Adult Research at our Cancer Center, and the director of the Mind-Body Program for Cancer Survivors. She specializes clinically in caring for patients and caregivers impacted by cancer, particularly young adults. And the focus of treatment often centers on the social and emotional challenges that occur after cancer treatment, including stress and anxiety, coping with uncertainty, and promoting healthy behavior change. Dr. Perez's research centers on identifying solutions to improve healthcare access and delivery, as well as the emotional and physical health outcomes among underserved groups. And she has a special interest in the challenges faced by cancer survivors. So thank you so much, Dr. Perez, for talking to us about your program and the clinical care and research in that area.
Thank you, Dr. Peppercorn, for having me here, Devin, for organizing. This is exciting. I am so honored to be able to speak with our patients today. So let me start by trying to share my screen. And Devin, if you can, you guys can see this clearly? Yes, perfect. All right. So let's get started. I am a believer in the power of words and stories to convey a message. And as I think about the program and why we need the program that we have here at the Mass General, I thought it would be fitting to share a quote from one of my patients wherein they tried to describe what the challenges were that they experienced as they complete cancer treatment. I say it over and over, but it's that transition going from having cancer to not having cancer that's really strange. It's like, okay, I have cancer today, and then you come home and you're done. And for me, this quote, it really exemplifies, again, why it's so important to think about strategies to not only attend to the physical health of our patients, but really to that emotional health after treatment. Let's start with the good news. The past several decades have seen tremendous advances in cancer therapies, and these advances have led to a considerable increase in the number of survivors. As of January 2019, there was an estimated about 17 million, close to 17 million survivors in the US, and that number is expected to grow to about 22.2 million by 2030. And so with this increased survival, we're also seeing improvements in longevity. So over the next decade, it's anticipated that the number of people who will have lived 5 or more years after their diagnosis is expected to increase by about 33% to about 15 million. Now, with this increase in the number of individuals who are living with cancer, there's a newfound shift to finding ways to attend to the needs that emerge after treatment ends. And it's important because of the observed quality of life impairments that appear to emerge. That end of treatment signals the start of a really critical phase in the continuum of cancer survivorship. It sparks a new set of challenges for individuals and their loved ones. Patients report changes with this time coming quite abruptly, not knowing what they value, changes in the self, changing in family roles and social relationships. And now these changes happen many times during the cancer treatment, but it's sort of, there's another shift that happens after treatment. And that shift actually what happens quite unexpectedly. So survivors feel unprepared and distressed as they're trying to adjust to this new normal. So another image that one of my patients drew was they described this experience as feeling as if they're dropped off on the side of a highway after participating in a really high-speed chase, and everything keeps going forward and they're sort of left behind. So what are the challenges that our patients face? Well, Annette Stanton and colleagues came out with 2 key papers that documented some of the key challenges, some of the common challenges that emerge when treatment ends. And these challenges coincide with that aspect of being unprepared, sort of these things happening unexpectedly. So one of the things that our patients report is feeling abandoned by their care team. Abandoned as especially, not necessarily actively abandoned, but sort of the medical visits start to drop off. They occur less frequently and there's less of that sense of safety. The social support network, there's a shift that happens. So people are often ready to move on, excited, and they share this sense of relief that treatment is complete. But often that sense of relief is sort of in opposition to how patients report feeling. They feel shocked. They don't necessarily always feel like celebrating. And then because of this disconnect, they feel like they're doing survivorship wrong. There's something wrong with me, quote unquote. There's an urgency to return what life was like after treatment. So resuming work right away, but then feeling ineffective as they return to their role as a parent or as a spouse. You have patients who report body image concerns, sexual functioning, changes in interests. all of these things can get in the way of romantic relationships, which already have maybe suffered during treatment because of treatment-related side effects. And let's talk about those treatment-related side effects. There are things like persistent fatigue, random bouts of pain, difficulty focusing, neuropathy, word-finding difficulties. And so we have individuals who, again, expect a lot of these things during treatment, but after treatment, there's this automatic expectation that things will resume back to normal, but that normal now has changed. And so there's this feeling of just feeling off. So when we're looking at the literature, what you will find is that up to 40% of survivors will report having prominent psychosocial needs. All right, so those are their psychological, social, emotional needs. And this is beyond just the physical symptoms that tend to persist after cancer treatment. Nearly all survivors, to some extent, experience a fear of recurrence. This fear can be variable, with clinical levels seen in about 30 to 70% of survivors. Having a follow-up visit, symptoms that resemble your diagnosis, seeing a person you know or a public figure with cancer, all of these things tend to trigger fears of recurrence. Close to 20% of long-term survivors actually have clinically significant anxiety, depression, or post-traumatic stress disorder, PTSD. This can actually be seen in up to 10 years after diagnosis. And this is higher than what we commonly see in the general population of unaffected individuals. And another psychosocial concern that tends to emerge, and it has been getting more attention in the literature, is the financial burden that our survivors face after cancer treatment. So because of cancer treatment, individuals might lose their job. There may be changes in their functioning or their ability to do certain kinds of work. Some may actually start to experience what we call job lock, feeling like you can't change your position even though you might be unhappy because you're now relying on that job for insurance. So all of these factors combined have demonstrated or have been shown to kind of contribute to financial toxicity in individuals who've gone through cancer treatment. Now, we're talking about cancer, individuals touched by cancer throughout the age spectrum. And certainly when you're looking at the cancer population, there are certain characteristics that can predispose or make someone more vulnerable to having more emotional challenges after cancer treatment. One such group where we see this happening are adolescent young adult survivors, or what we call AYAs. So as defined by the NCI, the National Cancer Institute, AYAs are defined as individuals who are diagnosed with cancer between the ages of 15 and 39. And that's a really wide age range. But they comprise about 5% of the cancer population. Now, their prevalence might seem low when you compare them to cancer often diagnosed in adulthood. But what really drew our attention to the needs of this group is the limited progress that we were seeing in their survival. Essentially, those cancers that are diagnosed during this wide age range, they seem to be different. The side effect profiles are different, the outcomes are somewhat different, and much of this has to do with that timing of diagnosis, which is during a time of significant developmental change. And so that's essentially what unites this group of adolescent young adults. It's that timing of their diagnosis in relation to where they are in that developmental trajectory. Essentially, what you have is an adolescent young adult who is receiving news of a potentially deadly diagnosis during a time of peak physical, social, and emotional development. And so the end result is that you have a group of individuals who are challenged with navigating the stressors and the life challenges that are associated with cancer treatment, also while negotiating the normative developmental stressors that commonly underlie that transition from childhood to adulthood. So there's sort of an interaction that we're seeing here. And so for that very reason alone, the psychosocial needs of this group seem to be tremendous and surpass those that are that we see in older adults diagnosed with cancer. And to kind of hit this message home, think about all the expectations of the AYA life stage. During this time frame, you're establishing your identity. It could be your personal identity or your professional. You're learning how to become comfortable with who you are. You're making choices, becoming independent, graduating high school, dating, getting married, or maybe starting your own family. you're essentially trying to find your place in this world. And all of these changes, all of these transitions are largely altered or placed on pause at that time of diagnosis and treatment. And you're forced as an AYA to manage all of these demands and make really tough life decisions, all the while having limited coping and decision-making abilities or experience. And fertility, for instance, is one of those major milestones that we know are an area of significant need for our adolescent young adults. Having children is often considered a major life milestone, and a majority of our AYAs, if you ask them, they want to have children, or at least they want to have the right to decide. And it's not unusual when I'm working with my young adults, I'll have someone in their 20s who are grappling with this newfound desire to have children while their peers, that's far from their minds. But despite these drives, AYAs are often not aware of the impact that cancer treatment might have on their fertility. And many don't actually recall having these conversations about their risks with their providers. And so this loss of potential fertility is actually a potential failed milestone for AYAs, and something that actually has been shown to lead to an extended period of grief that can actually last for many years into post-treatment survivorship. And so the Institute of Medicine early in 2008 and thereafter came out with 2 separate papers that highlighted the psychosocial challenges, many that I named, that were faced by survivors, and delineated this post-treatment period as being a vulnerable period in the survivorship continuum, right? Because technically, when you're as a survivor, that definition carries you from the time of diagnosis and beyond. But what we're starting to really realize is that we really have to attend to that aspect of post-treatment, what happens after treatment ends. And so these reports called for the implementation of integrated care models where high quality cancer care included the provision of psychosocial care. And what they called for also was to really enhance the communication between patients and providers, and to find systems that better link patients with psychosocial care. Why is this important? Well, as I mentioned, think of all the challenges that emerge unexpectedly when treatment ends. If these challenges persist and patient psychosocial needs are not met, as we're seeing is happening, one of several things can happen. Over time, patients may learn to adapt and cope effectively in their own way, and we do see that this happens often. Other times, patients cope ineffectively. Sometimes they turn inward. Maybe they stop doing things that are important to maintain their health and well-being, like healthy eating, exercise, minimizing alcohol use, and all of these things can increase their risk for treatment-related morbidities, as we're seeing, so their risk for other diseases. Another thing that we're seeing is actually symptoms may go away temporarily and then they return later and persist many years after treatment. And so this is what I'm seeing a lot of in my own caseload, where you have individuals who come and they say, I don't know why I'm feeling distressed. I had cancer X years ago, and now I'm suffering and I can't seem to get over that. And so that seems to perpetuate these feelings of doing cancer wrong or doing survivorship wrong. And when you're looking, again, how are we doing with meeting these recommendations that are repeatedly coming up in the literature? Well, we're not doing so well. Patients are now identifying psychosocial care as a critical unmet need during that post-treatment survivorship period. And there are a number of factors that contribute to this. Part of it is stigma that unfortunately is tied to getting mental health support. Part of it is that patients don't have the language to describe their needs. There's a sense of feeling confused or guilty for feeling the way that they feel. Providers don't always ask, sometimes because there's so much to do. And also there's again, patients don't necessarily share. So there's a lack of awareness that this is something that needs to happen. Either way, we can do better to attend to those needs that emerge when treatment ends. And so that brings us to our mind-body program. Our mind-body program understands and recognizes that early post-treatment period can serve as a teachable moment. It can be an ideal time to deliver psychosocial care to patients that are treated for cancer, with the goal of taking a wellness approach to mental health. In a sense, instead of waiting for distress to emerge and become more complex, what we want to do is intervene early and teach patients strategies to manage the distress and to anticipate the challenges that arise during post-treatment in order to prevent the distress from emerging and to prevent the quality of life impairments that we are commonly seeing develop over time. And so what we're doing ultimately is to enhance resiliency, which is their ability to adapt and maintain functioning in the midst of stressful life events. And that's essentially the field of mind-body medicine. It takes this wellness approach. It's based on this idea, this recognition that the way we think about things, our feelings, our emotions, our behaviors, our relationships, they can all have a profound effect on our body and vice versa. And so what mind-body medicine tries to do is to teach tools to help us, our minds influence our body. And they work in many different ways. One of the ways that they work is by deactivating that stress response. And it deactivates that stress response that we experience in the midst of chronic stress by upregulating that rest and relax part of the nervous system. In a sense, all the things that go haywire when we're stressed are back down to baseline. And I tell my patients that there's another thing that happens in our brain in terms of how we process information. The way I describe this is sort of thinking of a glass of water full of mud. And when you're in the stress response, it's like as if you're stirring that glass that's full of mud, right? If you're stirring that glass quickly enough and there's enough mud in there, thoughts, then you're not going to be able to see clearly. However, when you're practicing these practices, these mind-body practices, it's as if you're taking that glass full of muddy water and you're settling that glass down. And so what happens is the mud falls down. And therefore, in the midst of, again, ongoing stressful thoughts, you're able to see much more clearly. And I describe it, it's as if you're feeling in control of the uncontrollable. And so this is sort of a good segue into the basis of our program. My colleague, Dr. Park, designed a mind-body program to enhance patients' resiliency. And what this program says is that we want to teach individuals, and it's called the 3RP, a variety of stress coping principles, drawing from mind, body, CBT, cognitive behavioral treatment, and positive psychology. And it's the combination of these tools that can deactivate that stress response, sort of like medication, and therefore allows you to utilize these other stress coping techniques. So part of this program is teaching you how to elicit the relaxation response, how to do so, what works, what doesn't work, how do you approach this non-judgmentally, how do you establish a regular practice. There are many different tools that you can use, and so I'm not going to go through all those tools, but these are some of the things, the RR tools that we learn, things like Simple Breath Mini, for individuals who don't like to sit with their thoughts or meditating or breathing for prolonged periods of time. This is something that you do very briefly over maybe 2 or 3 minutes. And it's, again, a way to deactivate your thoughts. Sort of they're there, but you're not necessarily giving attention to them. The other focus that I mentioned with this program is learning strategies to decrease your stress reactivity. So this is becoming more aware of what stress looks like for you. What are some warning signs? How do you build your coping resources? How do you integrate other adaptive ways of thinking about situations, like finding the silver lining? Awareness is a key component of this program. We use an energy battery, sort of gauging, again, how am I feeling? Am I feeling that there are too many drains? And if I am, what are some charges that I can integrate to offset those drains? And then another feature is learning how to understand and tackle unhelpful thoughts. So identifying as stressors, understanding our emotions, and then reframing them in a way that's adaptive, not Pollyanna, but rather in a more balanced way that incorporates thoughts that we tend to dismiss when we're in a negative emotional state. And so in terms of this program is open for all individuals who have completed treatment or who are living with cancer. It's offered at least 3 times a year, sometimes more, and it entails 8 weekly visits, 8 to 9. And the visits are about an hour and a half, and they're done in a group. These groups are interactive. They consist of about 8 to 10 people. It's done virtually. We were doing them in person. And again, it's all learning relaxation response skills as a component, but other thought challenging and coping skills. So it's very much skills-based. It's focused on enhancing self-care, and it's really teaching how to apply tools to relatable topics. In terms of how we've done, well, we are tracking progress, and we're seeing improvements in coping and resiliency, changes in positive affect, decreases in anxiety and worry, depression. So we're seeing changes that are meaningful to our patients. And what we're hoping is to expand this. We're hoping to make this available to all our patients across MGH sites. We're hoping to make this sort of part of care so that as patients are transitioning from cancer treatment into survivorship, they see this as a way to prevent the emergence of other emotional distress that we know commonly happens. And given my interest in adolescent young adults, I'm hoping to have more specialized groups for adolescent young adults and also more specialized groups for our Spanish-speaking patients. And so to summarize, a cancer care model that adopts early integration of this mind-body program at the end of treatment has the potential to help survivors adjust to post-treatment survivorship and manage the uncertainty that surrounds their complex diagnosis. And in return, this can have substantial impact on their emotional, social, and physical well-being. And so that is hopefully our goal and should be our goal. And I thank you so much for your attention and your time, and look forward to discussion.
Great. Thank you so much, Dr. Perez. Really, really insightful. I was, this is recorded and this will be available on our webpage, but I was really thinking that this talk or some version of this is something I would like to prescribe to virtually all of my patients. So I'll be following up with you on that. I'm going to start, please send in some questions. If there's any specific questions about either of these talks, we'll try to screen them and answer them if we can. I've got many questions for both of you. We'll start with Dr. Perez. You alluded to this just now, that this should be, or could be part of standard care, and that the ideal time may be as people transition from the initial stages of care, cancer care, to the survivorship phase. But also earlier, you also mentioned that, people can have these kind of emotional challenges come up at any time. And I think you alluded to the fact that these issues also come up for people living with advanced cancer. So as a clinician, and your thought about timing is, is this for anybody at any time? How should patients and families think about this?
This is a great question, Dr. Peppercorn. Thank you. I think the ideal time is whatever an individual feels is the ideal time. This program can be both preventative and can also treat, right? So if an individual is experiencing heightened levels of stress or distress, then it's something that can be useful to them. For those who don't experience high levels of distress, we actually continue to see changes, increases in coping and increases in resiliency. So it's something that can actually help regardless of where people may be. My ideal for introducing it early on is, I think it's the goal of preventing distress. So if we can introduce this early and prevent distress, then maybe we won't see distress emerge in the way that we do in the long term. And in the case, if it does emerge in the long term, then I think something like a booster or redoing the group, that's something that I think would be feasible. So I don't know if that directly answers your question, but I think, again, it's really patient-led, but I think ideally as soon as treatment ends, and then any time is needed in the post-treatment spectrum.
Okay, that sounds like early and often to me, but I appreciate that. So Dr. Sullivan, let me turn to you a little bit different. I do have some questions about the survivorship aspect of melanoma that you asked, but also recognizing your background and expertise. I'm curious to know what are your thoughts on the frontier of this? This is such, most of us listening, including those of us who treat breast cancer, can't pronounce the names of half the drugs you mentioned. So other than folks who've been dealing with melanoma in the audience, this is all probably Greek, so to speak. But what's clear is there's been tremendous progress and it's getting better, and yet we're not curing everybody. So what do you see as the frontier research challenges, and where's the field going?
Yeah, it's a great question. So I think the most important thing that we've learned really over the last decade, although in many ways over the last 40 years, is that the immune system is a remarkably powerful tool to fight cancer. And really the goal of immunotherapy is to, I would say, inspire the immune system to kill the patient's cancer. That can't be achievable. there may be scenarios where the immune system just can't work, whether it's for medications or conditions or whatever it may be. And so that may be a limit. And I don't know if that's 5% of patients or 10% of patients or 2% of patients, but for the rest, we should be able to figure it out. This is just science. Like the immune system, every cancer that's been diagnosed has figured out a way around the immune system. We just need to figure out what like the cancers that don't respond to the drugs that we've developed so far. We just need to figure out why they're not responding. And you know, the thing that's so amazing about the immune system is it sticks around. It has memory. Everybody on this call has either had the chickenpox or the chickenpox vaccine, but we don't get chickenpox when we come across somebody who has chickenpox. You know, and so same with measles, same with any of the amazing, you know, vaccines that have been developed in the 20th and 21st century. And so that's, you know, we know that we can have a scenario where the immune system not only fights and gets rid of cancer in the short term, but then can provide like surveillance against the return of that cancer, which is so incredible and amazing. And so I guess my goal for my career, whatever is left of it, is that each year, each decade, we're getting closer and closer to filling in the gaps of the patients who right now, no matter what disease they have, aren't being cured with immunotherapy and figuring out how to do it.
Great, thank you. And hopefully those, you know, this is being applied. We're newly bringing these drugs into breast cancer, and there was an amazing study out of our national oncology meeting in rectal cancer, where it was very small, less than 20 patients, but every single patient treated with immunotherapy had their cancer disappear. So I think we've never seen more hope. So there's a question in the chat. I think that, Giselle, I know this is something you care passionately about. This is for an adult survivor, from an adult survivor of childhood cancer, who's just talking about, you know, they have felt they've had to be proactive and haven't really had long-term survivorship care, not clear where they go for mental health needs, let alone everything else, and they feel somewhat left behind by their doctors. I know this is a challenge in oncology. We do have some resources available. What are your thoughts for adult survivors of childhood cancer?
This is a great question, and you're not alone. And I would say it's harder because as a survivor of childhood cancer, what happens is you're not necessarily connected with your oncologist. But what I would recommend in that situation is hopefully you have a primary care provider who's within the system and they can help you get a referral. For instance, within Mass General, they can easily submit a referral within our system and can automatically connect you to our services. And there are people like myself. So the Psychosocial Oncology group within the cancer center, they often care for individuals who are going through cancer treatment, but there are many of us who specialize specifically working with individuals who are long-term post-treatment survivors. So you would be connected with one of us, for instance. But that would be my recommendation, is certainly connect with your provider and ask for a referral. You can go to Psychology Today if you find that your provider doesn't necessarily have the ability to make a referral. That gets a little bit harder because there's a lot to navigate there, but I'd be also happy if you have any questions to connect afterwards and provide some additional recommendations.
Great, thank you. And I think our last question, which I'll direct towards Dr. Sullivan, and I think this is relevant, certainly relevant in melanoma with what you've outlined in the survivorship needs, really, I think across cancer types, is as you enter this world, you've got people who are cured or hopefully cured, complex needs. And I know you, like me, are not necessarily an expert in everything else in internal medicine. I mean, we may be, we're trained in it, we're board certified at some point, but how do you balance the care between you and your clinic and the primary care physician? Oh, Ryan, Dr. Sullivan, did you get me on that one?
No, I temporarily was out.
Sorry, the quick question for you is, as patients enter this transition and they've got these complex care needs that you're trying to address in your clinic, but they also have primary care, how do you work with the primary care physicians in those years after follow-up?
Yeah, it's a perfect question. So when we are caring for a cancer patient, particularly using immunotherapy, it is so complex, and there's so many crazy things that can happen. Most time, most patients do fine, but there can be crazy things that, like, we want to know everything. And we are greedy. We want to know it, and we want to take care of it. And sometimes we'll, if it's something that's truly much more appropriate for primary care doctors to take care of, we will. But then once patients are through that acute treatment phase and the recovery phase, even if there's something like a thyroid problem that's going to be persistent, at some point we do pass the baton. And part of the goal of our survivorship clinic is to formalize that passing of the baton, so that we contact the primary care doc, say, you know what, we unfortunately caused thyroid dysfunction. Their cancer went away, so that's the great news. But they're going to need to be on thyroid replacement for the rest of their life. Would you please follow that, because it's something that you do all the time. Primary care docs are perfectly happy to do that, and they're thrilled that we've handed back a patient that they've referred to us with metastatic cancer. We still follow those patients, but they're taking care of the problems that are well within their toolbox to take care of.
All right, well, thank you so much to Dr. Perez and Dr. Sullivan, and to Devin for arranging this. Thanks for everybody who attended. Go to our webpage. You can find us, MGH Supportive Care Survivorship, on Google. There's a ton of programs available for patients and families. So thanks for everyone's attention and for joining us today. And happy Survivorship Month.